All right, well, I want to thank everybody for coming tonight, taking time out of your week to come here, and I really hope that you all enjoy what we're about to talk about, because it's going to be a bit nerve-wracking, and it's going to be, I think, very exciting, because I'm going to be talking about a topic that we all have to have thought about at some points in our life. So, to start with, I just want to get an idea of how many people have been associated with someone or known someone, taking care of someone with dementia. We've got every single hand in the room going up, so it's so common out there that it's everywhere. Everybody knows it. What percent do they do? What do you think percent they estimate of living Americans are going to come down with Alzheimer's disease in their lifetime? That's from newborns up to old folks now, because the incidence is increasing. What are some guesses? 50%?
80%.
What?
80%.
80%. Now I'm talking Alzheimer's disease, not mild dementia, not little memory, not senior moments. I'm talking about Alzheimer's.
35%.
So it's not actually quite that high. It's actually 1 in 7 Americans. 15%. Right now they're saying those at 65 and above right now, 10% are going to get Alzheimer's. And that of those all living, because the incidence is increasing, that 14, 15% in our lifetime will get it. So it's something that we all need to do about. So I'm going to start off by giving us, before I get into the whole dementia topic, I'm going to talk a little bit about the general approach to prevention. Those who are in my practice know this map. I'm going to go through it with everybody, and it's a general idea of how we approach the practice. So we are all kind of, this is meant to be baby boomers. We all think that we look a lot younger than we are, and we all want to be like these two up here, enjoying life at an old age. Pick a time, pick an age. We don't want to be like the guy in the wheelchair, but unfortunately, there's lots of people in the wheelchairs. Nobody anticipates that we're going to be there, but many people get there, and hoping that you don't end the wheelchair is not a strategy, and what we do is help to develop a strategy so that you don't end up like that. These are the root causes of disease. If you want to look at them, it's on the website, it's on the homepage, there's links to the different topics in here. But these are the root causes that lead to this man, and these are the healthy lifestyles that lead to these two. And what we do is we assess where do you want on the path. Most people are somewhere in between, and then move you from the right side to the left side of the path, which is distinctly possible. A little more specifics. I know it's small type, so I'm going to just bring you through. It's a general concept. If we all have the goal of maximizing our health span, living long is nice, but if you don't have your health, it's not good. It's like being in the guy in the wheelchair. He's what I call living in the gap. His life is still going, but his health is over, and he's living in a life of doctor's appointments, dependency on his kids, not enjoying life. But the people on the left are living, even if they're 90 years old. I had a patient of mine come here last week who's 95 years old, and he told me that even this year he's driven up to his place in New York 3-4 times because he loves to do it, and that's what's possible. So I got this actually from a lot of you in the room, because I asked my patients that what do you envision life when you're old? How are you going to be healthy? We need a healthy brain, independence, and as active as we want to be. So the next thing I do is I look at what are the big things that bring people down. The top 3 are dementia, heart attack and strokes, and cancer. They're the big 3 disease processes that bring people down. So what I do is I take a look at everybody, I see where your risks lie. Is it cancer? Is it cardiovascular disease? Is it dementia? And then we kind of go down the path that's most significant. And the root cause of all of these diseases are very similar. It doesn't surprise anybody that the root cause of cancer is similar to the root causes of heart attack and stroke and dementia. There are definitely some differences. So, and then we go down and we address them, we look for and identify the root cause. Even if you don't have any of these problems, if we can look at these root causes of disease, address them, then you may be able to prevent disease. So the value we do with prevention is to avoid the gap and to prevent the untreatable. Because certain things, like death from a heart attack, certain cancers, and I thought, until reasonably recently, Alzheimer's disease, that you don't get a second chance, so you've got to prevent the untreatable. So as I'm walking through the wellnesses for years with people, those who've been with me for a long time, they'll know that I haven't really talked much about dementia because it was a topic I was very frustrated by because nothing would work. It's a terminal illness that there's nothing to really do about. And so I would kind of not talk much about that topic. I would hope that heart attack and stroke prevention would also prevent dementia also, which is a reasonable approach until what I know now. So that's the big picture. So now we're going to dig in specifically to Alzheimer's disease. So what is Alzheimer's disease? It's a slow, progressive memory loss because of death of neurons. Neurons are all the millions of cells in our brain that interconnect like an electrical board that allow us to do all that we need to do as far as our brain is concerned. So with Alzheimer's disease, you get you get shriveling of the brain, you get loss of neurons, you get more death of neurons than growth of neurons, and it's from either direct processing going on in the brain, where you get an inflammation in the brain for various reasons. It produces a goo called amyloid, beta amyloid. It's a plaque actually produced in response to inflammation, but when the inflammation in the brain never turns off, you keep producing more goo, and eventually it gums up the motherboard. I use the example of one time I was out on my patio and I spilled a soda on my, yes, I was having soda at the time, but not now. But basically it spilled on there and it was all the sugar in there gummed up my computer and it stopped working. So that's what happens with Alzheimer's disease. It gums up the circuitry and it stops working. Our computer stops working. Or you get diseases of the pipes, the arteries that lead to the brain. It's the third leading cause of the United States, of death in the United States, third to fifth, depending on what survey you look at. They estimate that 50 million living Americans will eventually have Alzheimer's disease, and that's a lot of people. And until now, we've said that it's a terminal disease for which there's no cure. So you have in your brochures, you have this, and does everybody have brochures? Or Kirsten or Mary Beth, did you hand out some brochures? The slides aren't the greatest from the back of the room, but I've got some of these graphics on the brochures. But this is a graph basically looking at the changes in the death rate in the United States between 2000 and 2010. And across here, you'll see there's breast cancer, prostate cancer, heart disease, strokes, HIV. And for these diseases, we're doing actually a wonderful job in treating these diseases, so the death rates are going down significantly in all of them. But the one outlier on the right here is Alzheimer's disease. Because it is a terminal disease, people are living longer from these conditions, living long enough to get Alzheimer's disease. So there's been a 68% increase in the incidence of Alzheimer's disease in the 10 years from 2000 to 2010. Very depressing statistics. So don't worry about the words. In this graph, basically across here, we're looking at aging, getting older across the bottom here, and up here is perfect brain functioning, and then we're getting down at Alzheimer's disease down here. So over in this section of the graph is what we call preclinical disease. This is when the testing's all normal, but things are happening. The senior moments are creeping in. You're kind of having a harder time finding out where your car is in the parking lot. You can't remember what happened a week ago quite as well. So things are starting to happen. So there's subjective symptoms, but the testing's all normal. So this section right here is called mild cognitive impairment. That's when we start to see the brain function testing start to become abnormal. So it's getting a little bit more severe. And you'll see here there's 4 different curves drawn. So these top 3 are different variations of normal. It is normal to lose a little bit of our brain functioning as we get older. We all know some older individuals who are sharpened as a tack, and we'd love to be at that age. So this is normal brain deterioration. The problem is back here, you don't know if you're going to be on one of these 3 paths or you're going to be like Alzheimer's disease. So Alzheimer's disease, you transition from symptoms to mild symptoms, and then there's typically a rapid deterioration after that. about 5 to 12% of people with mild cognitive impairment transition into Alzheimer's every year. And there's typically a 5 to 10 year window between when you start getting into mild cognitive impairment and you formally get diagnosed with Alzheimer's disease. So that's when it becomes really urgent to do something about it. And one of the most telling examples I had in over the years is there was one patient I had. This guy published probably 1,000 papers. He was a scientist, smart as anything, loved having conversations with him. And he started having a little bit of mild issues. He was a genetic setup, like I'll talk about in a minute, but he was generally doing okay. He got really bad cold sores, herpes type 1 viral in his mouth get activated. It was really bad, a lot of pain. Kind of got that controlled, and within 6 or 8 months, he was a totally different human being. It was the trigger for his falling off of the rear end. By the time I saw him 6 months later, he didn't know who I was, didn't know who some of his family were. It was a rapid progression. So that's why it's important to really address things before it happens. So what's the cost? What's the cost of it? So there is financial cost, because home care is not reimbursed by medical insurance. Some people don't realize that. So the aids that are necessary for home care, things like that, they're not covered by medical insurance. The doctor's visits, physical therapy, yes, but not home care. People buy long-term care insurance, but that's typically doesn't cover the needs of even home Alzheimer's care, not to mention inpatient memory treatment facility. So a memory care facility doesn't cover the whole cost. So if people have long-term care insurance, you might want to go look at your plan and see what the monthly allowance is maximum and how many years it covers. So I found out when my mother needed long-term care for her Parkinson's that she only got like $2,400 a month, and it only covered her for 5 years. And that wasn't enough to cover everything, so it could be financially devastating. And not to mention that the burden it puts on your kids, if they care about you, they're going to help you, and none of us want it to be a burden on our kids. And then there's a total loss of dignity that comes with the disease. So, another question. What do people think it costs per month for a memory care facility, memory care nursing home? Any guesses? National average is a little more expensive around here.
8,000?
15,000?
13,000.
13,000. So it's actually the national average. Again, we're more. John got it the closest. It's about a little over $7,000 a month, and that's for a semi-private, not private rooms for it. And then again, this is nationwide. Pennsylvania is a bit more. All right. So that's the state of Alzheimer's disease. So now let's start getting into, should we start to be a little bit worried? Are one of us or one of our family members on the path to going towards Alzheimer's disease? So the first thing to think of is our genetics. So obviously there's going to be lots of genes that feed into our risk for Alzheimer's disease. So we'll obviously look at a family history. Anybody who has a family history of Alzheimer's disease, even no matter what their genetic tests show, ought to consider, because remember, 15% of people are going to get it. But this is a gene test called the ApoE gene test. And it's an interesting one, and it's been around for a long time. And I was being very selective for a long time in terms of whether I was going to suggest it for people, because it's in the heart attack and stroke program that I put together a few years ago, and it's been very successful, people reversing cardiovascular disease. It involves doing this test. And I actually had a discussion during one of the training sessions that we went through for it about, I don't like to test this on all my patients, because yes, it helped me know whether or not how at risk they are for heart attack and stroke, but it also shows how at risk they are for Alzheimer's disease. And that can be a very scary process and create a lot of anxiety in somebody. So I was not routinely doing it on everybody for that very reason. I didn't think there's anything I could do about it. Well, now I'm going back, and those who haven't had it done yet, I'm getting it checked on now, because I know there is a lot that we can do about it. So just kind of get an idea of what this is. With our genes, we get one copy from mom, one copy from dad. So all of our genes, we get a combination of two, either numbers, letters, or a combination of letters. And in this particular case, with the ApoE gene, It's some combination of a 2, 3, or 4. And what you'd like to have is a 2, and only 10% of the patients have 1 or 2 copies of a 2, and I've never seen a 2, 2, it's so rare. So that's not very common, even though we'd like to be that. The most common one is a 3, 3. About 2/3 of the population has that combination of 3, 3. What you don't want to have is 1 or 2 copies of the 4. Because what that does is we discovered that it acts on the genes of cells, on the nucleus of cells, and makes you more pro-inflammatory. The thought is, back in the days before antibiotics, when we were walking around the jungles and we were stepping on things and our risk for infection, that it makes us very pro-inflammatory. So we fire up an inflammation response to kill the infection and then it gets better. So that does have a purpose for it. And at that point, people didn't live past 40 or 50 years old, so it didn't matter if they were going to get Alzheimer's disease. But now we know that pro-inflammatory nature, if you've got a 4, makes you more prone to inflammation of your artery walls, and makes you more prone to inflammation that leads to that amyloid goo we talked about. So the statistics are that if you have 1 copy of the 4, you've got 30% lifetime risk of Alzheimer's disease. So it's about double the risk of the average person. If you've got 2 copies of the 4, then whatever age you are, you want to start working now. If you're 20 years old, start doing some of the lifestyle to prevent it, because it's a 50 to 90% lifetime risk of Alzheimer's disease. The risk of early onset Alzheimer's in 50s or 60s is 65 times the risk of the average person. So it makes you very at risk for early onset Alzheimer's disease. Now, if somebody goes back and looks at their testing, who are my patients, and see a 4/4, don't be disheartened, because it also means that about half the population is not going to get Alzheimer's disease, and there's something that we can do to help, there are lots of things we can do to help prevent it. And the example I like to use of this is I've got 2 patients in my practice, one of them who's here tonight. I love that part, so we can hear more of what we can do. But these 2 people are both 4/4, and one of them had a parent die at 70 years old of Alzheimer's disease. So that's a very scary thing. Bad genes, bad family history. But I did cognitive testing on this person, and it was a 30 out of 30. There's like hardly any subjective symptoms at all that would make us concerned about it. They're doing great. They're really doing well at 70 years old with that family history and that genetics. So I started querying a lot of the things that I know about what has worked all this time, because nobody's medical history is perfect, and neither is this person's. But what I found out was most of their adult life, they never snacked after dinner, so didn't eat from about 6 or 7 p.m. until rarely had breakfast, didn't eat again until 10 or 11 o'clock the next morning, so was going about 15, 16 plus hours without eating anything, and eating all the calories in an eating window of about 8 hours. Well, that's one of the more valuable lifestyles in preventing Alzheimer's disease. So, and this has been going on all of their adult life. So I said, I'm really convinced that choice of a lifestyle at a very young age is why you're doing so incredibly well right now. And I'm absolutely convinced you'll be doing well when they're 90 years old. So bottom line is that, yes, there's a lot we can do about it. You might be wondering why. That basically what happens is the body has to break out the street cleaners at nighttime while we're sleeping and break up that amyloid goo. There is ways to get rid of the goo. And if you do that, and to do that, you have to have the sugar levels being low. And by not eating like that, you keep the sugar levels lower. So there is lots of hope. This is just a list of the symptoms, don't worry about it, but the bottom line I'm pointing out here in this slide is that, is there anything changing? So basically, if they say that if you've got 5 or more symptoms, we need to be concerned, the ones I kind of said earlier, but most important, are there things changing? Which of those 4 paths are you on? One of the 3 normals or one of the ones that we have to be concerned about? So what do we doctors do to treat Alzheimer's disease? Well, the first thing we do is we rule out other causes. We make sure it's not your thyroid, check your B12 level. If you're depressed, we might put you on antidepressant, because I've had a number of people over the years who memory perks up when their depression goes away. So we rule out other causes. Check some basic labs. It's a pretty small list that the neurologists ask for when there's Alzheimer's. And then what do we doctors do best? We start them on a drug. There's a couple of drugs that are commonly used in Alzheimer's disease. And then we primary care doctors will typically send to a neurologist just to make sure there's nothing that we're missing because it's such a horrible diagnosis. And then this last one here says, get your affairs in order. I said that because there was literally one time when I sent mild cognitive impairment, sent the person to a neurologist. They came back and saw me. I said, what did he tell you? All I remember is he told me to get my affairs in order because there's not a lot we can do about it. And he started me on a drug. So I was like, this is just awful. And you talk about a depressing visit. So that's the standard treatment for Alzheimer's because, like I said, it's a terminal disease. So what about drugs? So there's been at least 245 studies on Alzheimer's drugs, and 244 of them show no significant benefit at all. We've only got 2 drugs. Neither of them improve symptoms. Neither of them cure Alzheimer's. They slow the deterioration maybe a little bit, and you have to get it started pretty early for it to work well. So the drugs just don't work. From the Alzheimer's organization says, despite all scientific efforts, at the moment, there are no effective pharmacotherapeutic options to prevent Alzheimer's disease. Drugs don't work. But even in the mainstream media literature, we're starting to get some clues as to what might work. So this is a quote from an article published by a professor at Harvard Medical School, where what she said was your diet and lifestyle can lower your risk of dementia. This was in May of this year. Time magazine, and also in May of this year, published and dedicated an entire special edition to Alzheimer's disease. And they even used the word hope on there. And so it was about at 70 or 80, 90 pages. Unfortunately, most of it was about the genetics and the drugs they're working on to target the genetics a little more specifically. But in the middle, in one article within this big magazine, they talked about the lifestyles and how they kind of listed off some of the lifestyles that have actually helped people improve some. So they're talking about the drugs aren't working and it might be work 5 years, 10 years down the line. There's one little section like that, you'd miss it if you weren't reading the whole thing like I was, talking all about lifestyles and where there's actually improvement. So, why are you here? So there's a program called RECODE. So you'll hear the term RECODE, for reverse cognitive decline. So it's a systematic program designed to slow down and possibly even reverse Alzheimer's for treating its multiple root causes. So what is this program? So there's a neurologist named Bredesen. He's a UCLA neurologist who 25, 30 years ago set off in his career that he wanted to cure Alzheimer's disease. So the first several years of his life, he was working in drug studies to help cure Alzheimer's disease. And then at one point, and he talks about his wife, and I'm telling you, that's his secret sauce as to why he's figured things out and nobody else. His wife is a root cause focused family physician like I am. And I can just picture the conversation at the breakfast table. Well, he's all frustrated because nothing's working. Of course it's not going to, none of these drugs are going to work. I mean, it's a lifestyle disease, and if you can just discover all of the root causes that lead to Alzheimer's disease, then you're going to make a difference. So the next several years of his career, he started doing that, and he talks about it in his book called End of Alzheimer, and I absolutely encourage everybody to read. It's extremely encouraging. So he goes through all the science of it, and he's discovered what he calls 36 holes in the roof that are the root causes of Alzheimer's disease. So basically, that's what the program's all about. He predicts there's going to eventually be discovered maybe 50 to 75 of them eventually, but right now we're at 35 to 40. So End of Alzheimer. So it goes through stories. It goes through all the science. There's some science-heavy stuff really meant for physicians, I believe, but just understand the big pictures, and it goes through what RECODE is all about. So what he did is about 2 years after he wrote the book, he developed a program to train physicians in his program. So I read the book about 2.5, whenever it came out, 2.5, 3 years ago, And last year I got certified in this method, and I spent the last few months preparing and now launching the program within the practice. Oh, a side note, before I forget, and I actually haven't even told these folks yet, that, well, they know that, but so one of the causes of Alzheimer's disease is oral bacteria. Those who know me know I talk a lot about that. I've kind of been launched in the dental industry talking about that topic. It's one of the more important causes. But so he and I are the two lecturers in an online educational series at the end of the month. Talking about dementia. We're actually going to be doing a promotional Facebook Live session on August 16th at 3 o'clock in the afternoon. So everybody will get to hear about that when anybody who's on Facebook. So it's fun. We've really got to bring it into the dental industry because the dentists really need to understand their role in preventing Alzheimer's and other diseases. Oops. So this is where in his book you're going to read about the holes in the roof. So if you have 36 leaky holes in your roof, you're not going to prevent the damage by patching one of the holes in the roof. And that's what the medicines do. They treat maybe one. None of the ones that we have active. There's one that supposedly addresses 4 leaky holes in the roof that's only available in Australia, not here. But that's why drugs don't work. So what we do is we look at the 36 leaky holes from general inflammation, high blood sugar, infections, sleep apnea, things like that. They're the leaky holes in the roof. Stated another way is we look at the root causes. So let's just say there's 36 roots that lead to Alzheimer's disease, that lead to the tree looking like this. These are the lifestyles and interventions that lead towards a nice healthy brain. And we look at these are the different root causes of Alzheimer's disease. So what we do is there's several tests involved, from blood work to a volumetric MRI that can look at the different volumes, the areas of the brain, because Alzheimer's typically affects one area of the brain called the hippocampus. So on this test, which I actually have right at Capitol Health, I was thrilled. There's not that many places in the country who bought this expensive software to look at that. We've got it 10 minutes across the river because they're trying to be the #1 neuroscience facility in New Jersey. But basically what it does is it measures it, and if you've got 75 percentile in the rest of the areas, but your hippocampus is at 30 or 40 percentile, we need to be a little bit concerned. There's lots of different puzzle pieces that we put together. And then what we do is we gather them, and we kind of organize them into the different categories that contribute to Alzheimer's disease. And there's 6 categories that Dr. Bredesen talks about. And the testing all looks at one or more of these categories. And I'll just walk through them each completely. So type 5 right up here is trauma. So you can't do anything about trauma, but if somebody's had a bad concussion, multiple concussions, we all, those we pay attention to sports, know that a lot of the athletes have early dementia because trauma is a big root cause risk factor. So we need to be, just like the ApoE patients, we need to be a lot more aggressive if somebody's had significant head trauma. What he calls type 1 Alzheimer's disease is inflammatory. So I mentioned the term inflammation before. Inflammation is actually a good thing. It was created to be able to help us fight infection, kill cancer cells, get rid of toxicities in our bodies. That's how we get rid of the enemy, is we kill it with inflammation. But when we have processes like bacteria of the mouth getting into your bloodstream, making their way to the arteries in the brain, and that inflammation that the dentists see on the gums are triggering the same inflammation in the organs that leads to things like heart attacks, strokes, pancreatic cancer, and Alzheimer's disease. So inflammation that doesn't turn off produces a lot of goo in your brain that does some bad things. Type 2, right here, is deficiencies. So there's inflammation, and there's deficiencies of hormones, and there's deficiencies of nutrients. He goes through a book of a lot of the nutrients, not every one of them, but a lot of the nutrients, and we want to make sure that you've got a lot of brain food on board. And although the program's not all about supplements, that's a component of it, if you need brain food, we give you brain food, and supplement what you're going to get in your diet. Hormones are important, especially thyroid hormones, adrenal hormones, that's kind of an adrenaline hormone family. It's an organ called the adrenal gland. And the sex hormones are all very important in maintaining brain health. 60% of Alzheimer's patients are women. It's not fair, I know. But why? Because estrogen and progesterone are important hormones that help maintain brain health. And in the training, they got pretty extreme. Now that we've got safe hormones to use for women after menopause, that's a whole different discussion I'm just going to touch on. And now that we've got safe estrogen and progesterone, those worries we had 20 years ago with Prevnar and Prevera, we don't have to worry about as much anymore. And women who are at risk for Alzheimer's disease, we're having a lot more discussions at menopause and beyond whether or not to go on hormone replacement therapy because it's so much safer right now. So, and they're even saying in the training session that even women who are older, like 10, 20 years after menopause, if they got mild cognitive impairment, really think about putting the women back on estrogen and progesterone because it helps to support their brain health. So type 1 inflammation, type 2 deficiencies of hormones and nutrients. Type 1.5, kind of tucked between the two of them, kind of a blend of the two, is prediabetes and diabetes. So that one condition gets a category of its own because there's a nickname for Alzheimer's disease is type 3 diabetes because there's such a close link to blood sugar problems and explains in the book beautifully why that is. That anybody who has prediabetes and diabetes is a risk factor of its own. Type 3 is toxicities. We're all exposed to toxicities. Air pollution, dirty water, pesticides in food that's not organic. And just a side note, I've just become such a huge believer that the best money investment we can have for our health is to buy food that don't have pesticides, get the organic foods. So that's poison to our GI system, and then one of the root causes of Alzheimer's disease is leaky gut and poor GI health. A lot of the root cause of that is toxicity. So that's one of the categories that feeds into it. And the testing we do looks at those kind of issues. Type 4, tucked in the back here, is vascular. Like I said, it's either a direct degeneration of neurons or the neurons are asphyxiating because they're not getting adequate oxygen. We get 5 times the blood flow to our brain, percentage-wise, than we do to the rest of the body. Oxygen is really important to the brain. Sleep apnea is a big risk factor for the root cause of Alzheimer's disease. So the brain, those fragile neurons need good oxygen supply, and so therefore, if the pipes are diseased, then you're at risk for Alzheimer's disease. And this was an easy one, because I've actually gone beyond what Dr. Bredesen talks about in his program, because we've been doing heart attack and stroke prevention for the past 8 years in practice. So just a note on that one. So if anybody's ever had a brain MRI, there's something called small vessel disease, with the itty bitty vessels that you can't stick a catheter in and open up with the cardiologist. And if you see on your MRI chronic ischemic changes, that means that it's little vessels in the brain are diseased, and that's a risk factor for Alzheimer's. So that's what we do. We gather the data, categorize it into 6 categories, kind of tell the story to the person as to why does it appear, what's your path then to where you are and where you might be going. And just like everybody who's on patient knows, we kind of walk through and give a completely personalized plan based on what you need, not worrying about the things that you don't need. And you don't need perfection. So this is meant to be a scale. What Dr. Bredesen says is that if you can patch enough of those holes, the rest of them slap shut on their own. You don't need perfection. All you need to do is to start having neuron growth exceed neuron death. Tip the scales from where if you're degenerating, you're having more death than growth, tip the scales, and then you can start getting neuron growth and you can at least stabilize, potentially improve. And I've got a very good friend who's in California. We did residency together. He's actually, because of an organization he teaches in, has known Dr. Bredesen for a long time. He implemented this program in his practice 2 years ago, and I'm modeling what I'm doing a lot after what he does. And he said that, Chip, look, it really is what Dr. Bredesen says, that he said so far we're getting about 2/3 of the people stabilized, and about half of those who are stabilized are actually starting to show signs of getting a little bit better. Their cognitive tests improving, families saying they're better subjectively. So it takes a lot of effort on their part, but it is going to have it. And what Dr. Bredesen is doing, he's gathering data to kind of show, to refine his method and see what really works and what's the most important things in the program. But you don't need perfection. So how do we do it? That's too much for this, but suffice it to say the cornerstone is nutrition. You really are what you eat. What we learned back in the 70s, it's oh so true, whether it's pesticide-laden food or poor quality food. Nutrition's there, optimal movement, healthy sleep, things like meditation are objectively beneficial. Brain games, there's actually one program, Brain HQ, talks about it in the book that actually has some data that it works well. Getting the hormones right, getting the nutrients right, getting rid of toxicities, and just basically finding out what your needs are, and these are the action plan, the personalized action plan. And it can't be all me. It's a team effort. And basically in the program, it involves the use of a health coach for teaching. And I'm going to take the opportunity to introduce Maggie over here. So she's going to be, she's a certified health coach, and she's been trained in both health coaching and the Rico Alzheimer's program. And she's going to be working with the folks in our program. I'll talk a little bit more about that in a second. But because there's a lot of teaching, there's a lot of reminding people because there's so much information. I mean, those of you who are in my practice know that I give you a long list. Imagine if your cognition's a little bit challenged. So she acts as an accountability partner, a teacher, a reminder. If you've got questions, she helps you out working with me behind the scenes. And I get involved, obviously, when I need to. The dietitian gets involved with the big program and so on. So it's a team effort. So let's talk more specifically about how we're actually executing this in the practice. I put a lot of thought into it, and here's how it's going to work. So the first thing I want to do is to clarify for people, because there's been a little bit of confusion, what we call it the Memory Treatment Center. Are you guys moving? Are you only going to be doing dementia care? What's happening? Are you going to have your regular practice? Nothing is changing for the core practice of Revolutionary Health Services. What I'm going to be doing is I'm going to be incorporating everything that we're talking about into the care of my current patients. Look, if your concerns are preventing a heart attack, because I'm not worried about dementia, because if I die of a heart attack, we're going to be focusing on that primarily. I'm going to be folding it into the practice, the precepts of it. But I'm also going to be offering it to people who are not in the practice, because this just isn't available at many places, especially to the level that we're doing it here as completely as we are. So we're offering it out, and this is on the website, to people who maybe don't live in the area, they don't want to leave their doctor, but they really want to focus on dementia. So the regular patients are going to be regular business as usual, full medical practice. The other folks are just going to be a deep dive into the brain and everything. It's kind of a full court press for brain prevention or treatment if there's problems happening. So that also opens up to people from out of the area too. So that's kind of the core program itself. So as I said, there is health coaching involved. That friend of mine in California has hired a full-time health coach as part of the practice. Eventually I plan to do that. How and when, I don't know. But for right now, we haven't worked out kind of the financing part of this and the pricing structure yet. But we're going to offer people who want an opt-in program for patients in the practice who would like to utilize Maggie as a health coach, to be able to, after we have our wellness evaluation, touch base with you 2 to 4 weeks later just to answer any questions, clarify confusions, remind you about things that you forgot about. Oh yeah, I forgot to get my shingles vaccine. I'll go get it. Those kind of things. So people who want to work in the practice or work more into this. And then also within the RECODE program, there's a lot of education. So there's 12 educational sessions through the course of the year that the formal full brain treatment center patients are going to have. And my vision is to have it in the office, and it's probably not going to be filled up with just RECODE people, but offer it out to the patients to who maybe want to just on a case-by-case or a lecture-by-lecture basis join it. So again, you're going to get more details. I haven't worked out the details of it yet, but these are kind of the three components. There's the medical component, there's the coaching component, and there's the educational component. So that's how the practice as a whole can get involved and do these things. So that's the program. That's it's very exciting. Part of my excitement is it's always bugged me because we all kind of do what we're interested in, even physicians. So in my family, a lot of Whitneys live to be 85, 90 years old. And but most of them by 85 or so, their brain is going downhill usually pretty quickly. And some of the older ones have had some pretty bad dementia by the time they got there. And anybody who knows me, I'm very competitive. I don't want to do that. So so when I learned this, and I learned what's possible out there, and then the sad frustration for 30 years since I graduated medical school, that not being able to do much about this, and arguably there's a certain point of life where people are way more worried about this than a heart attack. Because, fine, if I die of a heart attack, it's over. This is a devastation to people, and it's a scary proposition. So it's such an honor and pleasure to be able to offer. So I'm going to stop talking and open up for questions. Any question about the program, anything you want? Yes?
Can you clarify the difference between Alzheimer's and
Excellent. So her question was, what's the difference between Alzheimer's and dementia? So Alzheimer's there's a lot of overlap. So dementia is the umbrella term, of which there's cardiovascular dementia, which is disease of the pipes. There's Alzheimer's disease, and those two are probably 98, 99% of dementia. And then there's other ones that are similar but different, Wernicke-Korsakoff or Lewy body dementia, things like that. So there's subsets of them, but they're not the true Alzheimer's, where it's just a slow progression of symptoms based on. So actually, when we first see a person with memory problems, we can't actually formally diagnose them with Alzheimer's disease because there has to be change. So we say probable or possible Alzheimer's, and then over the course of time we figure it out, but we treat it like it's Alzheimer's. But honestly, I've got two parents with Parkinson's. That's a degeneration of a different area of the brain. I'm fully believing that that which prevents degeneration of the hippocampus for Alzheimer's is going to also prevent degeneration of the area that causes Parkinson's or the area that causes Lou Gehrig's disease, another devastating one. That's a degeneration that's terminal. So we'll know with time. I'm not saying it does that, but I'm convinced there's nothing else you can do. Might as well do this. Yes.
I know within it you have the issue of activity or exercise.
Yes.
But what's the significance of fasting, and how often should that be part of our experience?
So fasting, that's a loaded topic. I was actually invited to a 3-day seminar that talked about only fasting. Like, holy cow, what can we talk about in 3 days? And I saw an hour-long lecture about fasting. So there's different varieties of it. You hear about these 4-day water fasts where you do nothing but drink water for 4 days. There's actually a lot of physiologic value to doing that, but it's basically whatever a person is willing to do. So the thing I guess I'll bring up in this topic is that there's a difference between calorie restriction and fasting. So fasting is simply consuming your calories in a small eating window. So he talks about the 12-3 keto flex diet. Well, 12-3 stands for going 12 hours a day, eating anything, consume everything in a 12-hour eating window, including 3 hours before bedtime. So that's what he says for the average person. On the ApoE4s, the higher risk, he ups the ante, saying we really need to make it an 8 to 9 hour eating window because you need more time to be able to have the street cleaners come out and clean up the debris of the brain overnight and through the day. So that's the fasting part. So, and then there's the calorie restriction that you do or don't have to do with it. But it's really talking about just really consuming your calories in a short eating window in this context. It's about as short as I can make it for a complex topic. But actually, I'll say that for just longevity in general. I've got a friend who did studies at the NIH for 20 years on longevity. And I remember him telling me 10 years ago that the only lifestyle intervention that improves longevity in mammals is calorie restriction, fasting. So basically, it was mice and monkeys. They found that calorie restriction lengthened the lifespan of them. It's the only one that made a difference. And it just the more that comes out about it, the more so many different disease processes it helps out.
Thank you.
You're welcome. Other questions? Yes.
Well, actually, I have a question and a comment. What is a leaky gut?
A leaky gut. Okay, I'll try not to be too graphic. So, in the process, I'm going to apply leaky gut to Alzheimer's disease. So, in the intestine, and in the brain, and in the mouth, and other places in the body, we have barriers. We have barriers, like it's the intestinal wall in the gut. And what happens in certain cases is that there's tight junction that's supposed to literally keep the stuff in the intestine where it's supposed to be. With a leaky gut, you get inflammation, but more commonly you get loosening of those tight junctions so that the stuff of the intestines, the bacteria, the acid they produce, parasites, others, actually work their way into the bloodstream, spray everywhere, and the diseases can affect other areas of the body. And when you have one barrier leaking, there's a good chance that you've got other areas leaking, like in this case, the blood-brain barrier. Like the fellow I talked about earlier who had the bad cold sores, which is a herpes virus, in his mouth. I know what happened to him. It's very easy. He was already set up for Alzheimer's, probably had a lot of degeneration that we didn't know about, and his brain was flooded with these viruses that just fried his brain in very short order. But when slowly over the course of time, this is how the oral connection is. So like we probably talked about, when the bacteria in the mouth work their way into the artery walls and it leads to a heart attack, well, if those bacteria from the mouth, anytime you're bleeding, whatever bacteria you've got in your mouth are getting into your bloodstream, and if they're in your bloodstream and you've got a leaky blood-brain barrier, it's going to flow into your brain, and they've actually found two specific bacteria. One family called the spirochetes and P. javalis. You're hearing a lot in the news. I've had several patients ping me with the articles that they've been reading about that, where they're actually finding these bacteria from the mouth in the brain in Alzheimer's patients in such high quantities they can actually say cause-effect. It's one of the causes of Alzheimer's disease. So in leaky gut, it's a bigger topic, but basically it leads to things like irritable bowel syndrome, and it's a contributor to a lot of these diseases. So it's a defect in the barrier functioning of the intestine, which reflects other areas too. Yes?
In your opinion, what percentage of people follow your program once it's introduced? Say 100%. How many people change their lifestyle?
I wasn't sure where that question was going. So her question was, within my practice, what percentage of my patients actually change their lifestyle? Well, it depends. So, it's not 100%, but what I've actually gone to doing in my practice is I inspire. You're not going to push an elephant up a ladder. It's not going to work. I'm willing to put as much effort into my patients as they're willing to put into themselves, so I kind of stand at the top of the ladder, and I'll put in endless effort if you're willing to kind of do your part on the effort, because I can't control what you do at home. So I work through inspiration, and a lot of inspiration through information and taking the time to explain not what I'm telling you to do, but why you'd be smart to choose the choices that I'm suggesting for you. And then we have discussions in terms of, I know if I tell you to do 10 things, you're not going to do 10 things. So I kind of look for the low-hanging fruit. I say, people love it when I say, yeah, you need to lose a few pounds, and yeah, you need to exercise more, but you've got this marker that's really high. You really need to take care of your mouth before we work on anything. So I kind of pick off the easy ones and only have maybe one or two more challenging ones. And that's what it is. Again, you don't need perfection. The earlier you start, this is somebody's got mild cognitive impairment. It kind of needs a full court press, certainly if it's Alzheimer's disease. But catching it early before you have anything, maybe before you have anything or only have some symptoms, I kind of put people on a 1, 3, or 5 year plan, where I kind of just, in my own head, I say, okay, what's the time frame we need to implement, and what do we need to implement? At the beginning, I look for the easy ones and the most important ones, and then offer them out and try to explain why. So I have no idea a number. I've got more of the people who are motivated, and I'd have to say that because of the type of practice that selects people out who are motivated to make the differences, because that's what I love to do. I love to inspire people and show them how they can improve their health span. Did that answer your question?
Yes.
Good. Yes?
question on fasting and exercise.
Okay.
I've been trying to fast, like you talked about.
Yep.
And I love backpacking, and I do a lot of physical work outside, and I find at times that I get lightheaded. I try to solve that with water, but I guess the question is do you have to stick to it every single day, or if I'm in a condition where I'm burning a lot of calories more than normal, then I need to pour them in on those occasions?
Great question. So basically the question was, I know fasting is important. If I only fast 6 days a week or 4 days a week or 14 out of 15 days, am I going to ruin my efforts? Well, with fasting, just like almost everything, it doesn't require perfection. The more you do it, the better off you are. But yeah, you don't want to be lightheaded if you're out backpacking. There's oftentimes reasons for that. Maybe your blood sugar is low or whatever. Interesting as a side note about fasting is the best, most effective fasting is when you're exercising. So exercising in a fasting state, which I'm still having a difficult time wrapping my brain around because it just doesn't seem right. But scientifically, you actually get the best benefit if you exercise while you're fasting. As long as you don't have any symptoms from it. So yeah, so the answer is it's just like the scales. It doesn't take perfection. That if you know yourself and you know you're out backpacking for 2 or 3 days, then don't worry about the 12-3. I mean, just the benefit of the activity that you're doing probably exceeds the detriment you're getting from not having that day fast. So, yes.
How would you list, you said 1 dental hygiene, how would you list 1 through 5 as far as the most important things?
So what are the most important interventions for brain protection? I never thought of it in that perspective. Part of it depends on the person, so everybody might have a different top 5. And I say that some of the more beneficial ones are a ketosis-based diet. That's when you talk about the 12/3 keto flex. Basically, it's a ketosis-based diet. If somebody's too skinny and frail, then we don't do that. We modify it. That's the nutrition. I think avoiding the toxicities. I've actually got a handout that I'm starting to give people. I put together on basics on detoxification for everybody. Fasting is definitely on the list. Exercise is definitely on the list. And that's 4. So definitely nutrition. Sleep is probably, and oral health. Oral health is absolutely mission critical. And that's actually one of the easier ones too. So, and it's nice that I'm inspiring the dentists in the area to kind of understand it. And we've got one here tonight. So, yes.
So if you're an Alzheimer and not in your practice, how do you get involved with this program?
So what we do is we have it's a memory treatment center. It's on the website. Kirsten's in the back. You can talk to her about it. But basically, we launch people into the program, and it's in everything memory treating. And then we certainly anything that we do, we pass on to the person's doctor if they're not going to be a patient in practice, and basically take over the memory prevention and treatment. Kirsten's pretty good. Yeah.
Oftentimes, chiropractors push cleanses.
Yep.
Combination of fasting and supplements and.
Yeah. So the concept of cleanses, I had to apologize to a patient of mine about 4 years ago when I started to really understand the importance of leaky gut and intestinal health. And because he'd asked about 8 years ago about these cleanses, and I kind of poo-pooed it. That was totally unintentional, I have to say. But really good, I must say. Yeah, so what they do is they help you to kind of reboot your GI system. It's more than just a cleanse, but the cleanses really help to improve gut health. It helps with the mismatches in the mouth and in the lower intestine. There's a bunch of good bacteria, a bunch of bad bacteria. Over the course of our Western diet and Western lifestyle, we get a whole bunch of bad ones, not enough good ones. And through the use of cleanses, healthy eating, and probiotics, foods, and maybe supplements, you can kind of get the balance more back, and that allows you to kind of, and that's the first step towards healing leaky gut. Yeah, so, but yeah, there is definitely value in the cleanses. There's all kinds of flavors of doing that too. Other questions? This is great. I love lots of questions. So means there's an interested crowd. But it's if you think of anything afterwards, feel free to contact us. Anything specific about the program? Kirsten's in the back in the blue. She's the one you'll be talking to if you're interested. And for all my patients, when we do your wellnesses, we kind of discuss how we're going to fold everything into your care. All right, so we'll wrap it up. I'm hanging out here until they kick us out. And,